I want to welcome everyone to the quarterly merit conference. We have Andew Visco today, along with Bethany Leonhardt, presenting on interventions with high-risk youth. Really pleased that you guys are going to be presenting today and looking forward to hearing what you have to tell us.
Thanks, Paul. All right, let's jump in. Can everyone hear me okay? Okay. See heads nodding, so we're good. All right, well, again, thank you for having me today. I'm really excited to present with Bethany on the topic of interventions with high-risk youth. And again, I'm Andew Visco, and I'm a clinician at the Park Clinic in Indianapolis. And I've been working for a research group, the IU Psychotic Disorders Program, for the past 10 years in various roles. Currently, I'm a research coordinator. And then I've expanded my role to include clinical work around 2019 when I was finishing up my MSW program. So both Bethany and Jen Vose have served as clinical supervisors and mentors to me over the past several years, and were really instrumental in cultivating my interest in merit. So thank them for getting me here today. So thinking about our agenda for today, we're going to do a little intro or refresher on clinical high risk for psychosis, kind of what that means, what the state of things is, reflect together on our work at the Park Eye Care program, which was our first attempt at intervening with this population, consider the unique challenges involved in treating high-risk youth, and then think together about the use of merit with younger populations through review of some of the elements. So please feel free to stop me or Bethany with any questions along the way. And of course, we're looking forward to the discussion portion at the end to hear your thoughts on some of this work. All right. So clinical high risk for psychosis. Many of you are likely familiar with the term clinical high risk for psychosis as the prodrome or as prodromal psychosis. And so CHR is the common acronym for clinical high risk, and that refers to a phase denoting a risk for overt psychosis during which subacute symptoms often appear and cognitive functions may deteriorate. So that is a pretty broad categorization. So what are some of the common indicators that we see when folks might have some concerns that they are at clinical high risk for psychosis? So we've seen, and the literature typically suggests that unusual or intense thoughts, suspiciousness towards others, sensitivity to lights and sounds, worsening of existing symptoms such as anxiety and depression, and impact on functioning can be some of the first things that young people, their families, or important other people in their lives, like friends, teachers, or coaches, may notice and report. Many of the young people and families that I've interviewed and assessed would describe feeling that kind of something feels off or wrong. My thinking has been all over the place, or I've been thinking strange things, or strange things have been kind of happening, or from parents, so-and-so just doesn't really seem like themselves. They've always been a little sad or anxious, but this seems different. They're saying crazy things or doing weird stuff. But even with those indicators, we still find ourselves in pretty vague territory, because there could be several explanations for variations in behavior and cognition, particularly with young people. So with this population, there really is a high demand for assessment. At this point, kind of the gold standard is a screening tool called the Prodromal Questionnaire Brief Version, or the PQB, which is a brief scale that measures presence of various symptom criteria and subjective distress. So those who are rated a 6 or higher on the measure and are help seeking are then recommended to be interviewed using the SIPS. And the SIPS is a structured interview that seeks to rule out past and or current psychosis, rule in lifetime history of one or more of the 3 types of psychosis risk syndromes, determine the current status of each psychosis risk syndrome that is present, and rate the current severity of the psychosis risk symptoms. So ultimately, the interview would help to identify a diagnosis of a particular psychosis risk syndrome, along with the current status and severity. So they're listed out there as the BIPS, APSS, and GRD. And one of the things that I always find silly about this measure is it's called the SIPS, and one of the things is the BIPS, and I think there's also a BOPS and a POPS. So it's kind of comical when you get into it. But for the most part, what we were seeing for folks that were coming through the clinic, and I'll get into this more on the next slide, is that attenuated positive symptom syndrome was the prominent diagnosis that people were coming through and meeting full criteria when utilizing that SIPS. The genetic risk and deterioration syndrome is something that can kind of be added on to APSS and typically would be reviewed by either having a first degree relative with a schizophrenia spectrum disorder. And then also they would need to see a certain percentage of decline using a GAF measure within the SIPS itself. For the most part, we didn't really see anyone coming through with that diagnosis of GRD. And then for the BIPS, that brief intermittent psychotic syndrome, that would typically just be someone that is either currently experiencing a psychotic episode or has in the recent past. And so then we would typically refer them on to our CSC program. When reviewing kind of the literature and going over some of this, the literature does suggest that earlier intervention with those diagnosed with a psychosis risk syndrome combats the chances that a person might convert to experiencing a full psychotic episode. But even if a person does go on to experience psychosis, their subjective distress and overall dysfunction can be lowered as they already have been immersed in a treatment environment. But I would like to think more with you all about this idea because there are certainly pros and cons to being immersed in the treatment milieu where not every provider is utilizing a recovery-oriented lens. And this is certainly something that we found in our experience with the eye care clinic with physicians or residents that tended to be more risk averse or may not have been so immersed in kind of recovery-oriented thinking. So like I keep mentioning Park Eye Care. So that was our clinical high risk program, and the eye care standard for Indiana Clinic for Assessment, Resilience, and Early Detection. We were able to come up with that name and wanted to try and present something, well, trying to capture a lot in one name, but while also trying to still instill some hope for parents and young people that they're coming in with a certain set of skills, or they can build upon skills, or maybe even learn new things, and they themselves have this resilience within them to kind of get through the thing that they're experiencing. That this isn't a death sentence or something that's going to derail their life, that it's approachable and understandable, and we're here to help. So that's kind of how we landed on that very, very long name. But let's think a little bit about kind of our work that we did with Park Eye Care. And just for some background, around 2017, 2018, Sandra Eskenazi was gifted a donation so that a clinical high risk program could be established. It was specifically set aside for that purpose. So Jen Bose was really instrumental in getting the program off the ground and asked me if I'd be interested in providing clinical services following my completion of my MSW program at that point. So once I graduated and got my LSW, I started doing some service work there and working with her on getting that program up and running. That was a whole experience in of itself, but for our purposes here, we can stay on track. So I think it was 2019, we began recruitment and enrollment with a small team. So we had an MD and a couple of residents, Jen and I completing assessments and providing therapy, and one of our nurses, David Spradley, who also helped with referral processing, outreach and education, and metabolic monitoring. So it was a pretty slim team with a lot to accomplish with not a ton of resources. But we saw people actively through the better part of 2021. And ultimately, the program was shut down due to lack of funding, but we were able to transfer our existing clients who wish to continue services either to the Park CSC program, or they went with Jen to the IU Health side so they could have continuity of care. Over those years, 16 people were enrolled in the program and 12 received services from the treatment team. I think we completed over 60 or 70 referrals and had about 25 people that actually completed the SIPS assessment and process, and 16 were found to meet that criteria for one of the psychosis risk syndromes, and so were invited to enroll in the program. The rest, they were either referred out or sometimes we're lost to contact. We weren't able to keep up with engagement with them. But of the 16 enrolled, the mean age was about 18 years old. We did have several people that were 16. I don't think that we went younger than 16, but we were open to enrolling people as young as 12 if folks came through and needed assessment. So of those 16 for sex and gender identity, there were 6 female, 8 male, and 2 trans men who were assigned female at birth. And 13 of the clients identified as being white Caucasian, 1 client being Black African American, and 2 clients identifying as Latino or Latino. And of those 16 enrollees, all met criteria for that attenuated positive symptom syndrome, or that APSS. But the majority of people came through with additional diagnoses and met diagnostic criteria. And some of the most commonly comorbid diagnoses that we had were major depressive disorder, generalized anxiety disorder, PTSD, ADD or ADHD, OCD. And additionally, we had several people that met diagnostic criteria for substance use disorders, primarily either marijuana or alcohol use. So for several clients, personality pathology was also suspected, but due to the young age of the clients, a formal diagnosis wasn't provided at the time. And indeed, several people who were referred to us were ruled out due to presence of personality pathology driving the dysfunction in their lives. So for folks who did not meet those criteria, like I mentioned, we did rapid referrals within the Sandra Eskenazi system so they could access care at more appropriate programs. So we found that we were often referring folks out to the mood clinic or the base clinic, which was kind of the personality program. Those were our primary places where we were sending folks out if they didn't meet that criteria. But once in the program, clients had access to individual therapy, supportive family therapy, medication management and consultation with the psychiatric team, and metabolic monitoring. Our hopes were to begin group therapy as our census grew, but we were unable to get to that point. Clients were reassessed quarterly, and risk of conversion to a full psychotic episode was monitored. And if clients were suspected of converting or did endorse frank psychosis, then a rapid referral was placed to the CSC clinic down the hall, and they were able to begin services there fairly seamlessly. This was definitely a challenging program to get off the ground. The population experiencing CHR is relatively small, but the indicators of CHR are so vast. So that led to several people needing screening and assessment. And if we found that they did meet diagnostic criteria, there was still a complicated clinical picture to tease through. And this often led us to ask, what is actually driving the dysfunction in this person's life? And if we don't treat them here, are their needs going to be met somewhere else? So those were kind of the two questions we found ourselves asking the treatment team and returning to whenever we were considering folks for enrollment. Any questions about either of those slides at this point?
I'm not sure if we have it in there later, Andy, but can you describe a little bit just what attenuated positive syndrome is like, just for folks that have not encountered it before?
Yeah. So APSS, kind of the best way that I could describe it to parents, like when we were talking about like, what does this actually mean, is it was kind of like psychosis light in a way, kind of like Bud Light instead of Bud Heavy, where folks were endorsing these experiences that would kind of fall into this perceptual anomaly range, but wouldn't meet full criteria for a hallucination or a delusion. So for kind of the hallucination portion, oftentimes there would be audio components, for example, if I was walking in school, walking down the hallway, and I just hear someone yelling out my name, I turn around and it doesn't seem like anyone's really called out for me. Or I find myself at home and I think that I hear like the door opening and closing, and I go out to investigate and no one's there. One of the things that we found was that most people found these experiences to be confusing, but not necessarily super distressing. Like they were like, oh, well, maybe my mind's just playing tricks on me, and could come up with a reasonable explanation for why it was happening. For the delusional thinking, like sometimes people would present with some pretty interesting delusional thoughts or some suspiciousness. some persecutory thoughts. But ultimately, at the end of the day, they didn't necessarily think that it was actually happening. They kind of lacked that delusional conviction piece. They could talk themselves back. They could be like, oh, that was kind of a weird thing to think, but it felt really strong at the time. I'm not really sure what to think about it, but I don't really think it was real. So those were the kind of the common presentations that we would get. And additionally, nested into that APSS diagnosis is a degree of dysfunction. So oftentimes we would look at academic dysfunction or workplace dysfunction. If we found that they were significantly slipping in their grades, like up to a 30% reduction in grades, that was usually a pretty clear indicator that there was some academic dysfunction going on. And then similarly for workplace, if they weren't able to maintain hours or finding that they had to call off work a lot, or they just shared that they were feeling distressed by that experience, they could easily meet criteria for that. Trying to think if I missed anything. I think that those were some of the pretty common ones. Does that sound about right, Bethany? Yeah. Okay. All right. Okay. So kind of getting back to that, what's driving the dysfunction question. So given the complex presentation for each client, the demand to answer that question really is a critical one for our case conceptualization and appropriate interventions. And of primary concern for us as therapists is to avoid pathologizing thoughts, behavior, and changes that are consistent with the human experience of a young person. I remember when Barbara Walsh came through and was providing the SIPS training to a large group at Sandra Eskenazi. This was a question that came up from the audience often, was how can we really discern if this is typical human development that's appropriate for a 16, 17, 18-year-old versus what might be pathological. And I don't know that the SIPS necessarily does a great job at teasing this out. I do think that there is a high demand for your treatment team and your therapist to be able to ask these questions and get to the root of what's going on. So some of the things that we commonly found when we were asking ourselves what's driving the dysfunction were these areas. Oftentimes, like developmentally appropriate challenges for youth and young adults. Being a young person is weird and hard, and a lot is going on. We've got puberty going, shifting interpersonal dynamics with friends and family, stress related to academics and future planning, that interest in independence, but also still wanting very much to fit in, and identifying their sense of self and trying new things. So all of these experiences are complex and can create or add onto or complicate existing dysfunction in the lives of young people, or they might just be developmentally appropriate, and then the addition of those other things could lead to just a more complicated experience. Oftentimes too, like that distress related to symptoms, these weird things are happening, like those perceptual anomalies, fear, withdrawing from supports, decline in functioning, internalizing that struggle, like there must be something wrong with me, or it must be bad. I don't understand what I did to cause this, but I certainly don't like it and I don't understand it. And people seem confused by what I'm going through, and that makes folks uncomfortable. So I think that nests really well with this idea of stigma as well. Oftentimes people would find that they were nervous to tell others, they were experiencing shame, uncertain if treatment would really make a difference. They would often hear concerns from their family, or family would bring those concerns to us, like they don't seem like the teenager we used to have, or I don't recognize them now. Where did our kid go? Will they be okay? And trying to get a sense of where those ideas come from. And oftentimes the youngsters will bring up representations in the media of what it's like to have a mental illness. But in addition to that, they have, I do think they have more access and awareness of mental health concerns and perhaps what mental illness is, but still limited capacity to try and get a sense of how to manage their lives, or where to go to get help, or if help is possible. So it's like all of this information, all of this visibility, but a lot of uncertainty as to kind of what to do with that stuff. And then another thing that we often found that was driving the dysfunction was this emergence of personality pathology. In addition to that was oftentimes the family member that was bringing them, it was very clear that they had personality pathology that was kind of running rampant and seriously impacting the family unit. So oftentimes there would be a lot of interpersonal dysfunction going on in the family unit or with the client themselves and their peers. And then this component of kind of feeling shame at this for experiencing this dysfunction, but also kind of this interest in being interesting. I'm having this thing going on and I'm not sure what to make of it, but it does make me seem interesting to my peers when I talk about it. I think we had 3 or 4 folks that came through that would describe feeling as if they had dissociative identity disorder and would have like this very robust, sometimes these phone notes of various alters or ways that they were perceiving parts of themselves as unique people within themselves. And that is interesting. So it's sometimes challenging to discern if that is a component that is aiding into the dysfunction of their life, or is kind of keeping them in this prominent feature of being the focus of attention from other people. So all of this does pose specific challenges to the understanding of distress. We've got the CHR experience versus psychosis versus interpersonal challenges, kind of everything all mixed up at once. And I think this is why Merit really is so well positioned as an intervention strategy with this group, because of the elements and the demands from the therapist to try and intervene in some of these ways and really get a sense of what this person's agenda is, their psychological problem, and then how we can intervene appropriately. So I was thinking that we could now kind of get into some of the elements and think about some of the unique challenges and also the benefits of Merit and thinking about this complex group. But before we do that, I did want to kind of pause and think about any questions or comments that people had.
Andy, I don't know if you're going to get to this in the later elements, but I wonder if you could speak a little bit to what the metacognitive profiles were of the folks that you saw. If there was any kind of pattern that was pretty noticeable, or how impaired their metacognition was.
Yeah, we did get IPPs, I think, on more than half of the people that enrolled, but we haven't really gotten a chance to, 1, transcribe them, or 2, really look into them. I think anecdotally, thinking about some of the people that I was primary for, metacognition was kind of all over the place. Some people came in and had a pretty decent score for maybe S or O, but oftentimes I found that folks that were in that category were in a pretty high conflict home where discerning other people's emotions and thinking about their emotions was a demand. And so it's something that they were able to kind of cultivate in themselves pretty readily. But their ability to utilize mastery strategies, that would kind of be tanked out, and they weren't really sure what to do with all that distress or how to have agency in their lives. For some of our other folks that were perhaps like a little bit more barren, I can think of a couple of youngsters that just really had a hard time kind of even identifying a thought that they were having or an emotion that they were having. And so really started off in that pretty low range. But sometimes intervening with them was I think the progress was a little bit different, because being able to kind of scaffold from a lower level and build those skills with them in a seemingly healthy environment, they seem to kind of be able to attach to those interventions a little bit easier maybe than some of the folks that have those higher S's and O's but lower M's. But yeah, I definitely want to, when we have time, get into some of those IPPs and really take a look at them, because I think that there's a lot of rich and interesting stuff in there for sure.
Would you say, just like based off of your recollection, compared to like the patients that you see in the first episode program, do you think it's like about the same? Do you think it's lower? Do you think it's higher? Any ballpark?
That's a good question. I think it might be higher in higher for some folks because they haven't necessarily had to feel that significant distress and impairment in their lives yet. And because they're so young, their social relationships are still pretty robust. Like if they don't have necessarily a great family life, they at least have people at school that are interested in them, that care for them, and that are there to support and help them. So I think that those are certainly some of those protective factors. And one of the reasons why like that early intervention piece is stressed is so that we can kind of cut off that possibility of a large disruptive amount of dysfunction. But I think what I noticed too is that when people, might experience significant dysfunction, like being kicked out of school or losing their job, they were already in an environment where the demand to think about themselves and think about what was going on in their mind, they had already started practicing that to some effect. And so they were able to kind of cope with those changes or those disruptions a little bit better, maybe, than some of the Park CSC folks that I see when they do have a significant disruption in their life and then kind of feel pretty derailed by it. Yeah, that's a good question. All right, let's soldier on. So merit with younger populations. Let's go ahead and start with element 1, the agenda. And I think that this was a pretty interesting one for me to reflect on while I was building this presentation with Bethany. And I think one of the kind of the unique things is that for most of the clients that I saw, this was their very first contact with a therapist. Perhaps they'd seen a guidance counselor at school, or had seen like the school social worker here or there, but had never really engaged in a therapeutic relationship before. So oftentimes they really weren't sure what to expect. I do think one of kind of the accidental benefits of eye care being so small is that with Jen and I being the only ones to do the assessments and then to have the burden of or the caseload for therapy, was that we had already spent several hours with the clients prior to their first session of therapy. So at that point, we already had an opportunity to build some rapport. We've got some ideas of their story and what has brought them in. But I think kind of conversely, already having all of that knowledge could sometimes be a real challenge because it was really mixed up with other people's agendas. So many other agendas were present in the assessment room, from parents, siblings, grandparents, partners. So that demand to bring the client's agenda to the surface really was imperative, but oftentimes kind of challenging. I would find that sometimes people would arrive and they thought that their experience of therapy was kind of going to be a directive one. They were really surprised when I would give kind of the spiel about what merit was, that I'm here to think with you, or that I might not give a lot of advice. Kind of you're driving the session in a way. They'd be really caught off guard by that, and caught off guard by the question of where would you like to start today? People aren't always necessarily like wondering what's on their mind, and so they might struggle to identify like what their thoughts or feelings were. I think an important point to add on to that is for some of the folks that really were unpracticed with this idea of locating a thought or feeling or naming it, we found it really helpful to kind of just begin in the body and kind of stay in the body so that it was a little less intimidating. I've got this person asking me about my thoughts and feelings. I don't even know what I'm feeling, but I know like I have a sense that I'm sitting in this chair and I'm sweating profusely and my face is red, so maybe something's going on. We can start by noticing that. And so kind of staying there and thinking about perhaps like their agenda in that way was oftentimes pretty helpful. And noticing like what about their body might change from experience to experience, how it changes when I'm mad or happy or anxious or relaxed. And so then assigning those emotions and thoughts to those physical experiences would then often help people to kind of get a sense of what they're there for that day. And of course, we have to also contend with this family interest in service versus clients' interest in services. Oftentimes, like young people would say, I don't really know why I'm here, or I'm here because my mom told me I need to talk with you. I'm really not sure what I'm supposed to talk about with you, but like, I'll hang out if you want. So those sometimes it would kind of catch them off guard, or they had an idea of like what their parents were trying to achieve, but really uncertain as to what they were trying to achieve. And so being able to really talk with them and get a sense of, you were able to get in the car and come down here, or at least log on to the computer. Perhaps there's something that was on your mind or that you wanted to talk about. And so just starting there and trying to be approachable and elicit like what it was that they arrived to talk about that day. Another thing that we found was because the agenda might be more tricky to uncover, there really is an increased demand for the therapist to share their mind. And kind of additionally, I found that many of the kids really wanted to know what was on my mind, whether they were seeking advice or affirmation or someone to be on their side. And there was an increased request from them to know what I was thinking. I'd also found that the clients were fairly curious about me. It was kind of, again, like being that first therapist or adult that they're arriving to and talking with. They had a lot of questions about me, like, why are you asking me that? I think I understand, but can you say that in a different way? And so I think one of the things that was also helpful was their own flexibility. Like they seemed to be more comfortable with not knowing everything. That being said, I think that does come with some of the strength of the relationship, but it is an element that I found interesting as compared to some of the adults that I see who are a little bit more defended against that idea of not knowing things, or particularly like not having a sense of their own life and the distress that caused. I think a challenge that I often found or experienced was this kind of balancing act between inserting my mind in kind of a merit way, while also noticing that there was a demand for psychoeducation or exploring and combating stigma, and then also intervening appropriately for even just kind of some things that would seem like case management things, or maybe like everyday things. So in having several roles, sometimes I found that it was challenging to balance all of that in a session. And so I have a part of me that wants to kind of, we're talking about an interesting thing, or we're getting at something here, and then up pops this, I need you to write a letter so I can, have some more time taking my test. And so it's like all these things that you're having to balance while also, being a human and being the therapist in the room and sharing appropriate things. So that was certainly something that I found to be challenging over time. And then thinking about the narrative episodes, Bethany and I were discussing this, that oftentimes some of the youngsters really had this limited narrative availability because they just hadn't lived a lot of life yet. So they didn't really have all that many examples to kind of call back to, or stories about themselves. But in addition to that, sometimes folks would have this sense that it's always been this way, or like this is the first time I felt this way. So how am I supposed to reach back or pull back for another memory or another time that I experienced this? So kind of in inserting my mind, I found that oftentimes I would have to model those narratives for young people, or found it helpful to share if they were talking about, a concern, they're concerned that they're going to be a failure, or I feel like things are going well, but if I fail, I'm nervous that I might kind of slide back into how I was feeling when we first started talking. Being able to talk about times that I failed, or kind of modeling my own narratives about those experiences. What it might have been for me to interact with my mom when I was a teenager, how confusing puberty was for me, or how disruptions in my friendships and relationships, it was hard, and being able to think about those and talk about them with some of the young people, that was really helpful in kind of building their concept of what a narrative might be, or what these experiences might be if I haven't already had them. Additionally, really getting comfortable with immersing myself in a lot of the content that the kids were consuming. There was a lot of stuff there. A lot of kind of common interests that people would have, with a lot of anime, video games, board games, Dungeons and Dragons in particular, comic books, kind of classic stories and movies. All of that was really rich content to dive into with them. Because if they hadn't necessarily, had it, I don't know that most of us have an experience of vanquishing an enemy, but if I could like immerse myself in this really cool D&D character that I've built and researched and have interest in and can align myself with either their values or the way their behavior, that could be a way to kind of get at some of their storytelling and elicit some of these narrative elements. So that was certainly something that was helpful over time. And I learned a lot more about anime than I ever anticipated in, from 2019 to 2021. Still not for me, but, I got a working operational assumption about what some of it is. All right. So thinking about psychological problems, again, we're kind of going back to our big question. What's driving the dysfunction for this person? And also like what's driving the distress in their lives? Because sometimes they'd have dysfunction going on all around them, but it was something that they were relatively familiar with. Like my family's always been like this. Perhaps like my body feels really distressed, but in my mind, I'm just like, well, this is what it is. Eventually I'll move out and I won't have to deal with it. But oftentimes, again, like trying to elicit that agenda and locate feelings and thoughts within them, there was some nuance to that and some complexity. Oftentimes I was met with, I don't really know what I'm feeling. Everyone else seems comfortable, but I'm not. I feel angry all of the time, but what do I have to be angry about? My parents really pissed me off, but then I feel guilty about it, about being pissed off. And I think I'm just broken and I need to accept that. Sometimes it felt like problems would feel really big and unmanageable. They would have kind of this budding sense of self and who they were, while also wanting to maintain social status and social relationships. So this idea of kind of exploring those ideas felt like kind of shaky. I don't want to lose these people that are in my life, but I also feel like I might want to do something a little bit differently. And this kind of theme emerged for a lot of people that like being different is okay. I think this generation of youngsters is pretty comfortable with being different. They don't all have to be cookie cutters of each other, but being broken is something that's unacceptable to them. And it's something that they see often in some of the content that they're consuming, but also the state of the world. The state of the world isn't all that hopeful for young people right now. And so some of this doom and despair, it does feel like it's kind of set in. So being able to make that approachable can be kind of complicated, because that the world being on fire is not necessarily a problem that I can fix. But we can think about like you yourself and what's going on for you internally or within your interpersonal dynamics, or even like your curiosities and the things that you want to do in your life. And that can be a little bit more approachable and manageable instead of like all of these really, really large problems. And I think that last bullet here, this distress of the family unit and its impact on the client, oftentimes that was very central to the psychological problem that the youngsters are bringing up, is that it's kind of mayhem or chaos at home, or there's emotions flying around at home all of the time. There's not really room for my experience. Or I'm immersed in this really chaotic environment. I can detect and discern other people's emotions really well, but then I'm going into my social relationships and maybe I'm all that information isn't necessarily so reliable. So I'm kind of my head's on a swivel for rejection, or I think that people are being judgmental when they're not necessarily, but those feelings become conflated and they start to kind of tack those on to all of their interpersonal experiences. So sometimes I would kind of really conceptualize in my own mind, like being held captive by a dysfunctional family unit. That's oftentimes what it would get, how that person would present, is almost as if they're a hostage to their family unit and the chaos that it's creating. I can recall one client that Jen worked with heavily. who was a lovely young man, but his family was just a nightmare. And they were kind of calling all of the time to Jen, asking for these family meetings, and would just railroad through those meetings. And there was never ever room for the client. It was just all of this expressed emotion for mom and dad, and their own marital conflict and their own conflict for themselves and anxiety. And so the client would just kind of be off in the corner, and would really get lost in that shuffle. And so then when you're sitting in the therapy room with him and actually giving him some space to think and talk about what he's thinking and feeling, he just shuts down because he just is tired of exploring those emotions or hearing it from other people. And so even having that space can feel threatening. So there's certainly a lot to balance there. One of our kind of goals in the program was to eventually do some family unit group therapy so that we could get some families in the room, start thinking about some of these common problems and the impacts that it has on their kids or some of their own emerging psychological problems. We weren't able to do that. I can't remember the curriculum or the framework that we were going to use off the top of my head, but Jen had found it and was relatively excited about it. So I do wish we were able to explore that at some point, but perhaps in another time in the future. All right. So the therapeutic relationship, I think that this is one of the elements that was really helpful for me to think about and kind of put some words to at least the experience or the sensations that I've noticed I've been having when I'm sitting with some of these younger folks. The experience of being the adult in the room. I suppose I am an adult. Maybe some other people would contend that idea, but they told me I'm an adult, so here I am. So oftentimes like that comes with its own set of nuances. For a 16-year-old kind of talking about the content of his mind or what he might be feeling, or even like the drama in his friend group, I'm not really used to talking with a grown person like this about these things. No one's really like curious or interested in my life in that way. It feels kind of weird. They would often ask me like, have you ever felt this way before? Again, like that curiosity as to this recognition that I'm my own person, and I probably have a mind, and I've probably experienced some of these things before. And so being a little bit more open or curious about my own experience, or actually soliciting me for direct help. Like, can you help me talk to my mom about this? Like, I feel uncomfortable trying to share this idea with my mom. I think she's going to be upset. Usually the request would be, could you just talk to my mom about this? And then be like, well, I think that might be, there might be limited benefit in doing that. Maybe we can talk to her together. And so then that overture to kind of have me come along. But all of those were really great opportunities to think about our own therapeutic relationship, what it was like to sit with me or talk with me or think with me. Is there anyone else in your life that you can talk to like this? What's that experience like? How might this be different? Who do I remind you of? Oftentimes people would say that I reminded them of a coach or, a elementary school teacher that they liked from when they were in kindergarten or first grade. I think that's because of my stature. I'm pretty small and non-threatening. I feel like that could be a good sub-in for a kindergarten teacher. But so like there were these people that were in their lives that they had these experiences with, that they were kind of able to map onto the experience that we were having together. And oftentimes that felt comfortable. Sometimes it felt really uncomfortable for people if they weren't necessarily used to a grown person talking to them like this. They might fall into this position where the assumption is that I'm lecturing them or I'm parenting them or I'm telling them that they've done something wrong. And so being able to notice that when maybe I've slipped into this perceived role, being able to notice that with them and be curious about it was really, really important to do. So that really high demand, again, to have a sense of who am I, and then what function do I serve in your life? Yeah, and then kind of speaking to that last point a little bit more, like noticing those various dynamics. I found it really helpful to kind of say out loud, I'm feeling like you want me to do X, like what's going on? It feels like you want me to give you a motivational speech right now, or it seems like you want me to give you like a pregame talk. What do you think might be happening? And trying to get a sense of what they might have wanted in those moments, and then how we can think about that together. Additionally, sometimes people would kind of come out and we would be able to establish a pretty strong or secure therapeutic relationship, and then there would be some retreat, like perhaps I've shared too much with you, or talking about this, I'm noticing that I'm feeling pain or discomfort, and so this retreat back away from me. And so being able to comment on that and think about that with them was also very important. Like, you've shared scary things with me before, what's feeling different now? Or how can we think about this together? Or it seems like you're nervous that you're just going to kind of break apart into a million pieces. Did we push too much or talk about this too much today? So all of those inquiries were really vital and kind of getting at and noticing those dynamics. And then, of course, progress. I found that this is something that was relatively natural to do with some of the younger clients. And they kind of, a lot of them would often ask like for a progress report. And then you'd have to say, you don't get a grade for therapy, but I've noticed like these things. What have you noticed about yourself? I mean, I do think that might be, oftentimes I think there were a preponderance of clients that I had that would describe themselves as perfectionists, or were interested in doing well or getting a good grade or pleasing parents. So they want to know, like, how am I doing, or what do you think is going on while we're sitting together? But one of the things I noticed was really important was this importance of reflecting on progress in real time. Like, as I was noticing a shift in perhaps the way they were thinking about something, or being able to readily access a feeling when they necessarily wouldn't have been able to do that, a few weeks ago, noticing that with them kind of right away and commenting on it so that they could reflect on the change too. Like, what do you make of that? Have you noticed that? That seems different to me. What do you think? Like, what does that feel like to notice that thing together? But I think a complication to noticing progress is the challenge that young people have in their perception of time. Time seems really big and vast. The world's really big and vast. And so their ideas of kind of being immersed in this experience for 6 months feels like a lifetime to them. It's been 6 months of feeling like this, so it's probably going to be like this forever. I can't imagine not feeling this way. It took me so long to figure this out. I'm nervous about the future. Things don't necessarily seem so accessible to them in their concept of what the future might be like. So I found that kind of having this buy-in to the process of change was really an imperative. That recognizing with them that this might be an unsatisfactory thing to hear, but change takes time. Well, I don't know what time is. Okay, well, so it could take like a whole semester for us to make some improvements, or commenting on the past, like what we have achieved together. When I first met you, when you came in for your assessment 3 months ago, this is what you were like. These were some of the struggles. This is the stuff that you've been able to accomplish in the past 3 months. Like, what does that feel like? Or how can you kind of sense that timeline? And then being able to broaden that out so that this process of change does feel accessible for the future. And then this was something that kind of caught me off guard a little bit, was oftentimes I found people would express frustration when others perceived change in themselves or improvement in themselves when they didn't necessarily detect change in themselves. And I'm thinking of like 2 or 3 people off the top of my head who did have significant improvement in their relationships and their academic functioning, being able to identify their internal states, achieve some mastery strategies, to the point where one of them was even asked to do kind of like a little narrative about his life so that they could present that at like a mental health awareness thing that they were doing at school. And he seemingly happily agreed to doing that. And then came storming into my office like the week after and was like, I can't believe that they made me do that. Like, I don't understand how they think that I've changed so much when I just feel like shit all the time, or I feel like there's just all this screaming or rage in my head. And so trying, well, first of all, okay, come on in, let's talk about it. But being like open to that experience, that I suppose it could be frustrating when other people are having this sense that you've changed or you're different, when you still feel like crap sometimes. But also balancing that with this idea of kind of being different or being interesting, that was kind of one of the complications. And I think that kind of, I speak to that in this next section with S&O and mastery. Kind of being able to stimulate that sense of agency in youngsters is challenging. They don't have a lot of agency in their lives. Oftentimes, there's a prescribed routine for what's going on, or there's no routine at all, and they kind of have to make it up on their own. But that doesn't really feel like agency. That just kind of feels like survival in that moment. So being able to notice with them the things that they are able to kind of be active agents in their lives and what they are in control of, that was certainly an imperative. And then being able to scaffold with the client when life experience is limited. Again, like they haven't lived a lot of life yet. So being able to kind of make some of these subtle changes to themselves or how they're thinking, like that's nice, but how am I actually supposed to incorporate that into my life? Like, where are we going with some of this? What does this mean? And then being able, I think in terms of being able to think with them about problematic adults in their life. Like that was always a pretty accessible point of entry for that mind of the other piece, because those experiences are so deeply personal and they're immersed in them often. And then being able to think about that relationship perhaps with a problematic adult, and then what this relationship feels like. Does it feel different? Do you feel different when we're talking together versus when your rage monster dad is just kind of storming around, and going from there? But I think the point that I was thinking of just a few moments ago was this almost this embrace of the mental patient role, and I think that this part is kind of closely aligned with some of our folks, that it seems that there's some burgeoning personality pathology. Is this close alliance with this idea that I'm going to be like this forever, and there are natural consequences to feeling this way. It might mean that I have some limited agency, but perhaps that feels good. Perhaps it feels good to be taken care of sometimes. Or if, I've been taking care of my parents for all of this time, maybe I don't want to do that anymore. I can get sent away to a place where I just have to think about myself, or I don't really have anything to think about at all. And then coming out of that and being re-immersed into their life that's, not at a hospital, and noticing that might not be, a tenable course of action, that these things are going to keep going on. So there's that balance, that push-pull between wanting to be an active agent, but also not necessarily minding having some passivity in my life so that I don't necessarily need to take all the responsibility or control for what's going on. Kind of, again, that idea of stimulating agency and mastery when their autonomy is limited is inherently a challenge. And I think it was especially challenging when perhaps like they perceive the content of their mind not being approachable or understandable. If they find themselves in this fixed position that I'm ununderstandable, or that none of this makes sense and it's never going to change, being able to kind of stimulate some agency in that moment is difficult. And then lastly, like intervening with the family unit and the client, that was something we found that we had to do often. And of course, I think we can all relate to that. Like most of our clients don't necessarily exist in a vacuum. There might be other people there. So being able to balance the need of the client and the family unit, knowing that sometimes the family unit is driving that dysfunction, we need to do that. And that was something that I didn't necessarily feel like all that prepared to do in the moment when I kind of signed on to that role. The idea of doing family therapy was kind of nerve-wracking and scary, particularly when you've got parents yelling at you or yelling at each other, and there's a lot of disruption. I'm like, I don't know if I've got that in me, but finding the strength and courage to do that and having good supervision, like, that made the experience more accessible. But again, like, providing that support and psychoeducation. And that third one, risk tolerance. Parents really are very risk averse for the most part. The idea of their baby experiencing pain or confusion is unpalatable to them, rightfully so. But being able to balance, again, like, this normal course of development where independence is looming, and we want our child to be independent and have these life experiences, but the idea of them being hurt or injured in the process is really uncomfortable. So just being able to name that and identify that with that feature with parents and talk about it in an open and curious way oftentimes was pretty helpful. And then thinking about, like, emotion regulation. Yeah, there's a lot of things that are going to be outside of your control, but you can control how you respond to it in some way. And you've been building these skills to kind of notice your thoughts, notice your emotions. And now what do we want to do with that? We could explode over, all the time and drive everyone away, or we could diminish ourselves and curl up into a ball and not respond, or perhaps, like, there's some room to do something different in those areas. So again, just being kind of open to those things and scaffolding it appropriately, knowing that they have, like, some of that limited experience. And then I think something that's tandem with that is this idea that it's quite possible that you're going to experience failure in the future, and that's okay. Like, it doesn't mean that we have to break apart or that everything's unraveled and you have to start fresh. You've built some of these skills, or you've built this sense of yourself. You've pulled these ideas together. So sometimes that fear of failure is a little bit more approachable now than it was, perhaps when you first started here. All right. So that was the cruise through the elements. We have arrived to questions and discussion.
All right, well, I will just kind of have a couple of comments and then save most of the time to open it up to, like, a larger group. But I think I'll start with my reflection on mastery, since that's kind of where we wrapped up. So this is something that I think we've talked a lot about, Andy, like, in thinking about the folks that you've been working with at iCare. And I was told once by a clinician that was training with us that merit was a therapy that doesn't allow you to do coping skills, which is a mischaracterization of the approach. But I think that this is a particular issue with these younger folks who don't really have a lot of mastery and don't have a lot of agency, as you, like, correctly pointed out. And that there may be, like, an actual genuine need for helping people figure out adaptive ways to respond to emotions. Like, I was thinking in particular about your one guy who we've talked a lot about, who I think we kind of use the metaphor of, like, he doesn't detect his emotions until it's, like, at threat level midnight.
Yes.
Right? Like, he has no idea he's feeling anything. And then all of a sudden is, like, in the corner threatening to kill himself, but, like, can't detect how he got there or what led to that. And so in those moments, I think, especially when we think about merit with other populations, we often resist things like psychoeducation and coping skills, because that's such a knee-jerk response for mental health practitioners to immediately start explaining things away or trying to offer something without, like, really understanding what the problem is first. So I think oftentimes when we're teaching merit to people, we're trying to get them to stop doing these, like, bad habits of immediately, like, let's do a mood journal, or let's, jump in with 75 different DBT coping skills, and we don't actually understand what the problem is. But I think with this population in particular, like, there's not only do we still want to understand what's going on, but there's often, like, a genuine need to, like, kind of teach some of this stuff of, like, what else could you do in that moment? Like, are there behavioral strategies? And perhaps, like, they really haven't heard of these things before in a way that, like, often our folks who are, like, in their 50s, they have, right? They've been taught that stuff in different types of venues. So I think that's one of the things that's really interesting that you and I have talked about and thought a lot about in our work with this younger population of, like, how do you do that in a way that does offer them some constructive thought of how could you adaptively respond to this without it becoming like you are the one who knows, like you are the therapist who's giving them the coping skills, that's giving them the solution. So yeah, any thoughts about that, Andy? That was something that kind of came up to my mind quite a bit.
Yeah, I think that's a great question. And I thought of even a supervision session where I remember kind of coming into your office and being like, it seems like they wanted coping skills from me, but can we do that? You know? But then having a more nuanced conversation about that, and thinking about some of those ideas that, like, yeah, some of these strategies of how to confront life, they haven't had those experiences yet. So it would almost be unethical to not provide those things. I think some of the challenge is kind of slipping into some of those roles that we were talking about, like this idea that I'm a lecturer or a parent or your coach or your teacher. And so one of the things that I've tried to set out and doing, like even with commenting on our relationship, is if you feel like I'm parenting you, or if you feel like you're getting a lecture right now, please say something. Usually I'll be able to kind of catch myself if I get the sense that that's what's going on. I'll be able to notice that with them. But perhaps that's like indicative that I missed the mark on something. And so being me myself, being open to not necessarily getting it right was something I had to get comfortable with. But I do think that there are ways to incorporate and fold those things in. You just fold it in. I can't explain it to you anymore. That's a Schitt's Creek reference for everybody. But I think there are natural ways to do that with these younger folks, because they are still open to being taught about things and not necessarily knowing everything. Some of the kind of commonplace strategies we would often talk about would be these ideas related to behavioral activation and being able to notice that. Like sometimes you describe this sense that you're just gonna pop and just explode anger all over everybody. So like, we probably don't want that to happen. You probably don't want that to happen in your class. You probably don't want that to happen at home. You probably don't want that to happen with your friends while you're playing D&D. So what can we do, or how can we work to notice that that's happening, and then use some of these other strategies, like going for a walk or signaling to someone that, like, I'm not okay and I need a break, being able to have a moment to excuse yourself from that atmosphere or that environment. But that takes some planning to do. Like if you can't just get up and leave school when you're in high school. You can't just go out into the hallway. There has to be things in place to be able to make sure you can do that. And so that would be kind of a secondary conversation. Like, okay, so now we've got some kind of case management stuff to do. Who do we need to talk to so that you're able to have a pass to go out into the hallway or go to the resource room if you're feeling so overwhelmed? And doing those things together, so that it's not that I'm just like taking on that role or responsibility, but it's also helping them to have a sense of agency in their circumstance, but also learn some skills. Like, yeah, okay, I might need to send an email to somebody or get on the dreaded phone and talk to somebody, or have like a meeting. So who would need to be at the meeting? And then being able to incorporate a parent or whoever their grown up is to help them with that process. So those were kind of some natural things that unfolded and that we noticed could be helpful over time without necessarily falling into that paternalism. I think because the concept and the idea of paternalism was often on my mind working with these folks, because they are suddenly immersed in this environment where there's like professionals around. And some of us are a little bit more flexible to the idea that I don't know everything, and some people aren't. So I think sometimes when they might meet with some of the psychiatry team, again, like this concept of risk aversion or this concern, like this kid could ruin his life. And so taking away all of that risk and putting them into the hospital system so that suddenly like they don't have to deal with anything at all. And then coming back out to a life that's unchanged, they haven't really learned anything, but now they're significantly behind in their school obligations, or they feel strange that they've been away from their friends for 2 weeks, don't really know how to talk about these things. So then all of these other problems are created. And so I think that was certainly, that's a point where just doing something without explaining the purpose behind it, or being curious or inquiring or having an open stance, or even, that concept of dignity of risk for a teenager, that's when things would really get messed up and kind of mucked up.
Yeah, I think that's a really good point. All right, I have two more thoughts. And the second one is only half baked. So I'll offer these two thoughts, and then perhaps we can open it up to the rest of the group to share what they think, or maybe they can finish baking the rest of my second thought. But the first one, I think one thing that you and I also talk a lot about is this idea of narratives. And you mentioned this when kind of going through the elements, that this is a particular challenge with this group, in part because they don't have maybe a ton of life experience. But I think also there's been some work that's been done that shows that younger folks just in general tend to have lower metacognition, regardless of whether or not they experience a significant psychiatric disorder. And I think that's also like at play here, is that people are just not maybe at that age like used to reflecting on their life. And I mean, certainly if I think about what I was like at 20, I don't know that I was thinking a whole lot about what things were like for me at different points in my life. It's just, you're just kind of going and you're thinking about the future, and you're a little bit more kind of oriented towards the present and like what comes next, because that's part of like that phase of your life. And so I think that's been a real challenge in the work too, is like, how do you kind of help someone understand why those things might be important? And I was also wondering, like, I wonder if people need some distance in a way from those events, because like if they're thinking back to high school and they're 18, high school was like 6 months ago, maybe it's a little bit harder in some ways to reflect on that because they haven't really had the time and the space from it. Because it seems like a lot of times when you would ask people, like, when else have you felt this way? Or, what were things like for you in middle school? Like, people would just struggle to even answer those very basic kinds of questions to get them to think about like narratives in their life. So I think that's another just kind of key point with this youth population, is that just like they're not really attuned to like thinking about their life, and that there might be additional kind of scaffolding needed, or maybe even needing to go back to like narratives that are further away, like childhood, to kind of get to a place of more reflectivity before they can kind of do that about the things that are happening more recently.
Yeah, I think that's a great point. And that was something that I observed the other day with my one client who does tend to go to threat level midnight from 0 to 90. He is now graduated from high school and is in the workforce, kind of contemplating if he wants to go on for higher education or do something more like an apprenticeship in carpentry, has some various interests. But we were reflecting the other day. He was like, I feel like I've got access to my life a little bit differently. And I was like, well, what do you mean by that? And he was like, I remember we would sit together and you'd ask me, we would talk about middle school, because that's when a lot of his dysfunction began, when he started noticing anxiety and depression, or the sense that things weren't going well for him, but it seemed like everyone else was just fine. And he was always defended against this idea that perhaps there was something actually going on in his life that made him start feeling anxious or depressed. And he was very guarded against that, and just had this rooted idea that it was him. He was morally bad, and he was very unwilling to move from that point. And so in this session, he started talking to me. He was like, I was thinking about like my childhood experience the other day. And he's like, I suddenly remembered that like my dad was like really angry around me all of the time. And he recalled feeling unsafe physically at times, but also just like emotionally uncertain what was going to happen. He wasn't sure what would set his dad off. But I think the thing that he noticed in particular was how his dad's behavior changed over time. That as his younger brothers were born, it seemed that dad like made this concerted effort to become a better man or become a better father. And he started wondering like, well, why wasn't I good enough for that experience? And I do think that's a function of development. I'm not sure exactly still what happened or what kind of clicked for him, but to be able to have some distance or separation, perhaps even from his family unit, like he's spending more time by himself or out in the workforce, or he's got plenty of time at home by himself. And so not always constantly being immersed in this family group, but having some time to have his own thoughts. I think that it made some of that stuff accessible to him. But I think that's a really good point. And we need to like continue thinking about it because that it makes a difference. I've noticed that with a couple of other clients too. I've got a young woman who is, when she first came to us, she was pregnant at the time, and post-pregnancy after the birth of her daughter, that's like when she did end up meeting full criteria for psychosis at that point. But being able to kind of reflect on her experiences after this milestone, it was very different than when she was still pregnant and kind of thinking about her life in the past. Like having this separate experience of being a mother herself, she was able to reflect more on the experience with her own mother, who was often emotionally dysregulated and abusive. And so it's that nuance in having some lived experience and being able to harken back to that to be able to inform what's going on in my mind now.
Okay, I'll offer my half-baked thought, and then we can open it up to the group and see if anyone can either finish this thought or other thoughts or reflections that have come up for everybody. But I guess I was thinking about this clinical high risk group and sort of the phenomenological and like sort of philosophical sense of like, what is this prodromal state? So when we think about schizophrenia, you know, we talk about this fragmentation, this sort of like profound fragmentation and the collapse of the self that happens when somebody experiences prolonged psychosis that is often diagnosed as schizophrenia. And I think in this group, it's different. Like people have not had this full collapse of the self. It's starting. There is like this fragmentation that is definitely starting and is profound and is impacting their functioning, but it's not the same level. In part because the self is still like developing and informing, and not that we ever think that like you're at some point where you have a crystallized self. That's not really how we think about how that works, but it's still so in flux in terms of development. But also the distress people are feeling is not also at the same level as people with psychosis. There is like some fallibility that remains. People can say like, I think that this might be true, but I'm not sure, or I think that I heard this, but they can kind of stop themselves. So I guess this is my half-baked thought. Is just I think it is a phenomenologically different state from psychosis, but obviously is related. And so that I think that doesn't inform what we're doing when we work with folks. We're trying to think about like, you know, how do we kind of stop them from going into a place where they would experience the full fragmentation that can come with psychosis, but also I think trying to help support like developing parts of self when the person is still like so young and kind of figuring things out. So I'll throw that out to the group. I don't know if that made any sense, but it's something I kept returning to when I was like reflecting about this topic.
Bethany, I don't know if it's directly related to what I found myself thinking, but I guess, and great presentation, by the way, Andy, is really interesting work. It seems like pretty clear, you know, rationale for how this approach can be impactful with younger people. But I found myself thinking like, is this a case against the specialty clinic? Is it a case against the labeling of the high risk group? You know, I know that there were some things like the onset of the pandemic that complicated the recruitment strategy, but with the having like more specific boundaries of what this group is, and then also the tendency that you noted of people really kind of glomming on to the kind of sick role, or like, I don't know how much people actually identified with the label of attenuated psychosis, but I mean, it just strikes me as a group that has a lot of different potential trajectories out of it, and getting this kind of support seems incredibly valuable. But I don't know if it seems like in a perfect world, we would not be labeling them anything, or maybe not sequestering them out of a kind of general mental health clinic where there's fewer trappings of like, look how different I am, or
Yeah,
signaling to the family of and maybe it's just really variable depending on who they encounter. I mean, it occurs to me that at a lot of places that might have this model, that people are more likely to run into the attitudes that you mentioned in the residents rather than your openness. So I'm not sure exactly where the question mark is, or if I linked to Bethany's comment, but it seems to be somewhere in the same general area. I'd be curious to know what your thoughts are in response to that, though.
Yeah, I do see a common link there. Like, I think it's really reasonable in my mind as I'm kind of shaping and forming my identity and my sense of self. I have kind of this disruption that's going on, but my life certainly isn't in shambles. But there are parts of it that I would like to be different. But depending on, I suppose, like what the person's agenda is in that moment, there could be some reprieve in glomming onto this role or glomming onto this diagnosis. Perhaps like that could excuse me from having to deal with all this responsibility that I didn't really ask for from my family. Or perhaps like I can join my family in being wild, and there's like a reason for it that's reasonable and understandable in some way. But I do think kind of that idea of, I don't know how helpful the labels are. I do think that there's a market shift when you're doing those assessments. You're kind of talking with the parent, you're talking with the client, and then it's like you have to come into the room and give this diagnosis. And no matter how I tried to like appropriately veil it from a recovery oriented lens, they still walked out with this idea that something has gone wrong. And so that means I now have to come to this building, I have to talk to this person and try and like fix something. And I don't know what that is. So I wonder if there could be a space in time where we have like a clinic that's approachable. Like I think these are common experiences that maybe not all or most young people are having, but that a lot are. And so to have a space to talk to someone that isn't going to panic or freak out, but we're able to talk about my life and think about like how this could be helpful to me now, but also in the future as I'm building my sense of self, that is helpful.
I think, and just to respond to your comment too, Jay, about like, is this an argument against the specialty clinic? I think if like mental health care functioned differently and there wasn't such pervasive like stigma within providers, yeah, absolutely. If we could do merit in all kinds of, youth clinics across the US, I think that there wouldn't be a need for this type of clinic. But staffing the referrals for this clinic, it's just wild. People do not know what to do with psychosis. The minute anything even approaches a psychotic phenomenon, they're just banging down our doors to get people in because they don't know how to think about it with them. So I think if there were more people that were trained in merit approaches that could, especially with this population who's like, they have fallibility, like that is such an important thing to like intervene with and think with them about and to capitalize on. But I don't think there's just such a lack of training and such pervasive stigma that I don't think that these folks are well served at all in other clinics. I think that it really did help to have a place, because the way that our funding works, we can't take them until people have experienced a full psychotic episode. And so it really feels bad at this point when we get a referral for someone who would have qualified for eye care to send them back out to like other clinics in the area, because they're not going to get this kind of treatment. The practitioners often react with a lot of alarm and stigma around these types of experiences. So yeah, I wish it would be better, but I think that if we could get funding for eye care again, I would do it in a heartbeat.
I have another thought about this too. This is Nancy. So I work in a clinic where we work with folks with first episode and with clinical high risk syndromes type things. And one other thing too is that while there can certainly be problems with labels and diagnoses and things like that, sometimes when I've been doing the SIPS assessments and then we kind of give feedback to the families that that their children or that themselves are like eligible given this like clinical high risk indicator and stuff, like sometimes they're actually really relieved because they've been rejected from a lot of services before. Like Bethany was saying, like whenever there's a whiff of anything that looks like psychosis, like people can kind of like freak out and be like, oh, you're too high level of care for me and get out of here and I don't know what's wrong with you. And they've had these really bad experiences. So sometimes when we give them that feedback that they might be experiencing these attenuated symptoms that suggest a higher risk in the future, but you're in the right place now, and we can like help you to, stack the deck in your favor and stuff like that. They can be really, really relieved to have that. So just kind of putting that perspective in there too.
If it's possible to kind of touch on Bethany, what you mentioned, and then Ashley's comment when right before she jumped off, is thinking about what it is to have a sense of self and one's role, and kind of how we think about or structuring who we are as individuals. A lot of the adults I work with, it seems as if something happened and their ability to understand themselves is kind of emergent from this more complex whole diminishes. And so then they grasp onto like one role that they have, and like that's what they know. And thinking about with adolescence, and I'm thought what came up for me is during the presentation is this idea of like people's engagement with media or fantasy or anime or any of that. And some of the children that I've worked with, and that was their way of understanding themselves, right? So I don't have this access to these like larger narratives, but I have access to media that then I can kind of project into or associate with. And that can be helpful for kind of structuring or kind of scaffolding a sense of myself or how I might deal with problems or how to think about or approach things. I'm curious to what extent working with adolescents, that type of stuff could be brought in. I had a kid I was working with that was a product of rape, and parents just both really hated him. And he was really into this anime called Naruto, which I looked into, and like it was essentially mimicked a lot of the experiences that he had. But I wonder if with these adolescents, there's then some type of fixation on or some type of focus on that type of role preemptively, and then it's flat or empty and it doesn't allow them to continue to develop, right? So if I'm going to grab onto this role of I'm the failure, or I'm the hurt one, or I'm the angry person, but then that is kind of what they're stuck with. And I'm not sure if that makes sense, or if there's any exploration of like, okay, well, what are other ways we can think about this development before we kind of close on this? And I know labeling that for my adult clients has been really helpful, when I be like, okay, so now you're telling me that you're just the crazy person, or you're the scared one, or you're the failure, or you're the, I don't know, the oppressor. And then that's something that they can then start beginning from. So I think that some of this is disconnected, but these are the thoughts that came into my head right now, and kind of trying to tie together a couple of the streams of questions that came up during this discussion period.
At least, I mean, thank you, Andy, for that great presentation, and Bethany, all your thoughts. I had two sort of thoughts also that were floated in my head as you were talking, and one of which is, we do think that metacognition is something that develops, and we don't have any good information on at what point certain things start to develop and what facilitates those. And so there is a way in which, in this work, we're flying blind without a good way to know whether what we're seeing is psychopathological, metacognitively versus not. We know from Sean Davis's dissertation that O seems to gain significantly across adulthood, whereas others don't, but we don't know anything about it earlier. And relatedly, I think we also know narratives tend to get stunted with the event of psychosis. People tend to have fewer or earlier reminiscence bumps, which is to say that their narratives are populated with earlier and earlier memories and not later ones. And so naturally, this is a group seemingly at risk for that. And I wonder to what extent the work you're describing, Andy, sort of keeps the evolving narrative alive. I guess the final thought is I am impressed at the more extreme need to join with the patient in being confused than we see with older folks. This is, as you pointed out, a time of gross confusion and uncertainty, with less resources than in adulthood to make sense of it. And it seems like an essential part of your work is to begin by being confused with people, not dispel it with expert advice, but to try to find your way through it. So those were a couple of things that popped in my mind.
Yeah, I really appreciate hearing all of everyone's thoughts and having this opportunity to kind of think and reflect together. I think we're just about out of time.
It looks like we are just about out of time. Are there any final thoughts before we say goodbye? And
now, thank you all for attending and listening and offering your thoughts and engagement. So I appreciate it.
yeah, thank you. Great stuff. Andy, and thank you everyone for coming.